Okay, we're going to pick up where we left off in class, and that's with Chapter 2 in terms of health issues and also quality assurance. I talked a little bit in class about the agency that regulates hospitals, and I abbreviate it as JCO, so it's Joint Commission. And what this is an agency that establishes minimum quality of care for hospital facilities. And in establishing that minimum quality of care, what happens is then hospitals can be evaluated to see if they're above the minimum or below the minimum. And those are used with regard to ratings. People look at those, particularly in bigger areas where you have multiple hospitals. And an individual might decide to opt for one hospital over another. But on the other side, people use those to decide whether a hospital should stay open or not. So JCO tends to be a very important regulating body when it comes to hospitals. Other more definite accrediting measures have happened in the past future in 2009. And as I said, you have these very program-specific requirements with regard to standards. And understand these are minimum standards of safety for not only the patient, but also JCO will set patient to healthcare provider numbers and various things that go into what equates to quality control, quality assurance for a patient entering a particular hospital on all levels, with regard to care, with regard to cleanliness, with regard to the bedding and everything that goes into care for the patient. More information about JCO in terms of what they do, and basically just to be aware of JCO and its vast reaches when it comes to healthcare organizations. Then the next thing that I mention this in class all the time, we call them CLIA waived tests, so the Clinical Laboratory Improvement Amendments of 1988. And this is probably where the instigation of wearing gloves for bloodborne pathogens came in, because it was the not so much the healthcare, say the RNs, the surgeons, etc., that weren't wearing gloves. It was the medical assistants, the phlebotomists, etc., that weren't wearing gloves, and anybody who didn't choose to wear gloves. But other things happened with regard to the CLIA enactment. There were things that were called CLIA waived tests, and I talked a little bit about those in class. But what this did was set the quality control for all personnels in all offices. So outside of hospitals, so say doctors' offices, and understand that because doctors' offices are sometimes associated with hospitals, they do have to pay attention to JCO, but they have other regulating bodies that they also need to pay attention to. And what this does is set standards for things that are done by all personnel, and that includes phlebotomists, medical assistants, clinical laboratory assistants, so people who have some education or learned on the job. And this has to do with such things as the temperature with which chemicals are stored, the expiration dates for tools, the expiration dates for, say, UA reagents supplies, how often certain refrigerators have to be recalibrated in terms of their temperature. So all of these things, so not only what the individual does, but how things are stored that are going to be used in testing for anything for a particular patient. And these CLIA wave tests are expanding as we speak. It's a huge growth industry because a more I guess, as I said in class, and I don't mean to offend anybody, but somebody who has less education can do the same test as long as insurance will pay for it, and they can get results that either can then escalate the insurance, escalate what insurance will pay for, or escalate the test that could be done, or can be used as a diagnostic result. Then you have other regulating agencies with regard to accrediting agencies for clinical labs. When you go on your clinical site, it's important that you go to a site that has a regulated, accredited clinical lab to get your 100 hours and 100 venipunctures. So not all labs are accredited. And basically that looks at it. So not all places that blood is being drawn are accredited places, and that is needed in order for all of the rest of the portions of healthcare to fall into place. So in order for you to get your 100 hours to become certified, you need to go to an accredited. This is your aspect of this, but all other medical lab personnel, like medical lab technicians, etc., need to go to an accredited lab for their continuing education, everything that can't be done in the classroom. This concept of quality and assurance is one of those abstract concepts that come back to bite us often. I talk very much about pre-analytical errors. I talk very much about certain aspects of your blood draw. One of the things that I've already said in classes is once that needle is unsheathed, you are committed. You're going into somewhere. You're not waving it around. You're not unsheathing the needle and then saying, I don't know where to put this needle, because the needle is sterile and you want it to go into the vein right away. So this idea of quality assurance is an entire overarching program of everything you do to prevent problems and to prevent pre-analytical errors. This actually is database driven, so certain areas of where there are problems have been looked at. Certainly dirty needle sticks in your department are a huge problem. They have been looked at, and areas to try to mitigate dirty needle sticks have been tracked and tried to help through. So tracking where the problems show up, the outcomes, and what solutions might be useful for those problems. And with regard to quality assurance, you have these indicators that need to be measurable, well-defined, objectives, specific, and very much related to a problem that can affect a patient's care. So their care or even your safety. So these are indicators of quality assurance. And then quality control is the component of quality assurance program. So it's a component of it, basically putting the results of all that data into play, into what they do. In our class, my results of data is to fuss at you. Probably maybe not the most scientific result, but fussing at you in terms of how you are regulating the sterility of that needle. But hopefully the fussing is a little less intimidating than somebody writing you up for a job or something else, which actually could happen. But what happens is checklists are put into place, particularly you think of this with surgery, and monitoring performance. That's what I'm doing with the fussing, is I'm looking at your performance, and you're starting out, so please understand that I understand. I know that you're starting out. But that's what happens with quality control. It happens all the time to try to improve these pre-analytical errors. In terms of preparation, I think the big thing about this is the most serious, egregious error that we can make is to misidentify a patient. So remember, patients have rights, and we need to get their approval to do a venipuncture. So you have to ask them in some way. It can be a benign way, like, "Hi, I'm Jan, and I'm here to draw your blood," and then see what the reaction is. If the reaction is, "Oh, like heck you are," then I think that's not a approval. But if the reaction is, "Oh, okay," and they put their arm out for you, you can say that that's them saying they are interested in getting their blood drawn. Anyway, the other thing with regard to patient identification is make sure you have the patient that corresponds to the test requisition. You also need to prepare the patient, as we said in class. You explain the technique not in great detail, and definitely let them know when you're going to put a needle in them. The patient's record is a legal document. I know some of these PowerPoints are a little more involved than I need for you to hear from my lips. But remember, I'm not telling you everything that's on the test, but I'm trying to get you in the ballpark of the things that I think are important. And that is a chronological documentation of all of their care. And one of the things that we are trying to do, that they're trying to do, is have those records be electronic, so that chronology follows them, and that you have the chronology. I know some of you have had the same pediatrician, then you move into your family practitioner, and some people stay at a family practitioner that they started out as a pediatrician. So their medical record is long and extensive. But we do have, anytime we note something, it needs to be legible. So if you're somebody who has exciting, beautiful handwriting, you want to adapt and put very, very clear writing down, very precise, very complete, and no cross-outs, certainly no whiteouts. If you cross out, and then make sure you are documenting that cross-out that you did it. We use this documentation to talk to each other so that we know what somebody else has done. And it is a legal document. It can be hauled into court, and unfortunately when it gets hauled into court, it really gets some eyes looking at it. Legal issues, you have civil courts, which are torts, and you are subject to tort types. So you are subject to assault, battery. You are also subject to malpractice. It sometimes is encouraged for you to have malpractice insurance. One of the things probably that would be your result of one of these possible tort complaints might be a firing, but really, for being sued in civil court probably wouldn't happen to you, because basically they sue the richest person, and that would be the hospital. But you would still want to watch out for this, because you could lose your job because of a possible civil suit or tort offense. So you do want to be familiar with that. And then I think we'll stop here and pick up on the next one, because these are only 15 minutes long.